we have mentioned at the end of last session. If you remember, it was asking about alcohol that was ingested by a person and it affected his brain, and then it got released, or part of it got released in the urine, so it reached its kidney. All right, so starting first was the small intestine. Remember, small intestine would be drained through the superior mesenteric vein. And if you remember, small mesenteric vein is one of multiple veins that will drain into the hepatic portal vein. So your first vessels that you're going to be traveling through is going to be superior mesenteric vein. Next is going to be hepatic portal vein. And then if you remember, this going to be conducting the blood to the liver for the toxins in the blood to be detoxified. So my next station here is going to be the liver. After it gets modified, the blood going to be drained out of the liver through hepatic veins. It's going to be number 4 to reach my inferior vena cava. If you remember, inferior vena cava is one of 3 different veins through which the blood is going to be returning back to the right atrium. So your next station is going to be right atrium. After that, blood is going to be moving down from the right atrium to the right ventricle. And then will be, so here, while you are passing from the right atrium to the right ventricle, don't forget to mention here the name of the valves that you're going to be traveling through. It's going to be the tricuspid valve. Yeah, so the question, you're going to go in order. So this was the only questions that we've had last class. So you're going to just numbering the different vessels and cardiac chambers and structures. All right. So you're going to be passing through the tricuspid valve. And then you're going to reach number 8 here is going to be my right ventricle. And then number 9 is going to be the pulmonary semilunar valve. And then I pass here through the pulmonary trunk. And plus or minus here, if you want to add the pulmonary arteries, this is going to be fine. And then you're going to reach lungs. This is going to be number 11. Next is going to be the pulmonary veins. That will conduct the blood down to my left atrium. And then blood from the left atrium going to be traveling down to the left ventricle, passing through the mitral valve. Here is going to be my left ventricle. Left ventricle is going to be pumping the blood out, passing through the aortic semilunar valve, and then through the ascending aorta. Told you when you get to the ascending aorta, just slow down and look back at where you wanted to go. You're going to the brain. So how would I get to the brain? Remember, all the arteries that are supplying the brain are coming from the aortic arch. So you're going to go here, ascending aorta, and then to the aortic arch. So this is going to be number 18. On the test, you are required only of stating just one pathway, one possible pathway. You don't have to mention every single possible one, or you're going to be limited to the pathways that you're going to be traveling through according to the sequence of vessels I'm giving you. So for example, if I told you, for example, 18 is aortic arch, and number 20, for example, or let's say 21 here is right vertebral artery, or let's say 22, right vertebral artery. So what's going to be number 20, 21, 19, 20, and 21? What do you think? Those are questions number 1, 2, and 3 for today's class. Those are questions for your in-class activity 1, 2, and 3. So you're going from the right aortic arch to the right vertebral artery. So you're going to go first, brachiocephalic, exactly. Brachiocephalic artery. And then, if you remember, brachiocephalic splits into right subclavian artery, and right common carotid artery. So looking here, your next is going to be right subclavian artery. And next is going to be right vertebral artery. So number 3, you just skip it. You just put nothing for number 3. All right. So again, what we're looking at in here, we're looking at how do we conduct the blood from the aortic arch to reach the brain. So remember, the brain, in other words, you are trying to reach the circle of Willis. So what are the alternative pathways? If I take brachiocephalic artery, I take subclavian artery on the right side, right subclavian artery, to the right vertebral artery, to the basilar artery, This is going to be one pathway. So brachiocephalic artery, right subclavian, right vertebral artery, and the basilar artery. This is one pathway. Another pathway might be here, brachiocephalic artery, brachiocephalic artery. Next is going to be right common carotid artery, and then right internal carotid artery. And right internal carotid artery. Next is going to be circle of Willis. Other pathways include left common carotid artery, left internal carotid artery, and then circle of Willis. Another alternative pathway is going to be left subclavian artery, left vertebral artery, to the basilar artery, and then to the circle of Willis. So again, which pathway, whatever you are limited to in terms of choices, this is one thing. The other thing, if you are just listing, just pick any single route through which you're going to be able to reach your target organ. So whichever works for you is going to be fine. As far as you reach the target organ, it's going to be fine. Questions? All right, so I did reach the brain. Is this one on here? So I did move. This one. This is the one from today. This is the first slide from today. All right, so I've moved from the small intestine to the brain. Remember, how do you get the blood back from the brain? We're gonna mention the details today, but generally speaking, the brain is gonna be drained through the internal jugular vein. If you remember, it meets with two other veins, which are external jugular and the subclavian vein, which we don't need to state in this pathway. We just need to state the ones through which I'm traveling through. All right, so internal jugular vein will conduct the blood to my brachiocephalic vein. Pick any side, either right or left, it doesn't matter for us in this section. And then brachiocephalic vein drains into my superior vena cava to my right atrium. And then we're going to be doing the same pathway like as we've mentioned earlier. So we're going to be passing through tricuspid valve to the right ventricle, to the pulmonary semilunar valve, to the pulmonary trunk, to the pulmonary artery, to the lungs, and then from the lungs, you're going to be draining the oxygenated blood back to the heart through the pulmonary veins. To the left atrium, down from the left atrium through my mitral valve to the left ventricle, and then from the left ventricle, I will be traveling up through the aortic semilunar valve to my ascending aorta. And again, when you get to the ascending aorta, look back at where is my destination. I am going from the brain to the kidney now. So what is my destination now is my kidney. So I'm going down to the kidney. So remember, kidney is an abdominal organ. So you go here from the left ventricle up into the ascending aorta. And then from the ascending aorta, you're going to travel aortic arch. And then you're going to mention that you're going to be traveling here through the descending aorta. And the first part of the descending aorta is going to be the thoracic aorta. Then I will be passing through the diaphragm. The descending aorta will now be called abdominal aorta. And remember, renal arteries are direct branches from the abdominal aorta. So you're going to go renal artery to the kidney, and then the kidney gets it filtered out in the urine. All right. Any questions? Any questions on how do we conduct the blood through the vessels and how can we name the vessels through which the blood is going to be traveling? All right, so moving on to the next part of this chapter in which we are discussing the histology and physiology of the vascular part of the cardiovascular system. So starting first by definitions, what is an artery? If you remember, an artery is a blood vessel that carries the blood away from the heart, regardless of whether it's oxygenated or it's deoxygenated. Compared to the veins, veins will carry the blood towards the heart, again, either oxygenated or deoxygenated. A third type of vessels that we're looking at in this chapter is going to be the capillaries. And the capillaries, those are the smallest type of blood vessels, which will allow a direct exchange between the tissue cells and the blood. Looking here at the different types of vessels that we have in the body, you can see we have the arterial system, starting first with the largest type of arteries. Those are my elastic arteries. Elastic arteries will keep dividing into muscular arteries, and then muscular arteries will keep dividing, giving rise to the smallest type of arteries. Those are my arterioles. Arterioles will be conducting the blood now to the capillaries, which are embedded between the cells of the organs. And the capillaries will be draining this blood out of the tissues into the post-capillary venules, and a venule is a small vein. Traveling here from the venule, blood is going to be traveling to smaller veins, small veins, and then to the large veins that will end up getting the blood delivered another time to my heart. If we're looking at the systemic side, systemic circulation, this is going to be my right atrium, and this is going to be my left ventricle. So again, what are the different types of blood vessels that we've got? We've got arteries, we've got veins, and we've got capillaries. Arteries are carrying the blood away from the heart. Veins are carrying the blood back to the heart. And the capillaries, those are the exchange vessels that would be embedded between the tissue cells in order to allow the exchange between the blood and those tissues to take place. If we're looking here at the structure, and this is an important diagram for your upcoming lab exam. This is an important diagram. Looking here at the difference in terms of structure between the artery and a vein. If you notice on here, each of those vessels has 3 layers. From inside out, we've got the tunica intima. Next is going to be the tunica media in the middle. And to the outside, we've got tunica externa. Tunica intima is going to be formed by the layer of epithelium, one row of flat cells on either the veins or arteries. This is called my endothelium. We've got a very delicate layer of connective tissue. It's going to be areolar connective tissue underlying this endothelium, and this is going to be my subendothelial layer. In the arteries, we're going to see elastic tissue layers, but not present in the veins. Moving out from the tunica intima to the tunica media. Tunica media, as you see in both arteries and veins, is going to be formed of muscles, and the type of muscles that we've got in our vessels, this is going to be a smooth muscle. In the arteries, we've got an extra layer of elastic tissue, which is not present in the veins. To the outside of it, we've got the thick fibrous connective tissue layer. This is going to be my tunica externa. So again, 3 main layers in either veins or arteries. Those are going to be tunica intima, tunica media, and tunica externa. If you notice on here, major differences between the structure of the artery and the structure of the vein. Veins will have valves, as you see. And this is needed in the veins in order to prevent the blood backflow. So why don't we need valves in the arteries? Because simply the arteries have a high pressure. So the blood travels at a high pressure due to the ventricular contraction. So it ensures that the blood will keep moving in this direction, and there is no chance that it can be moving back towards the heart through the arteries. But here in the veins have very low pressure, and in some cases, the pressure in the right atrium, for example, here is going to be around the zero pressure. And I need to move the blood against the gravity. For example, I'm moving the blood up back to the right atrium from my leg veins. How would I be able to move against the gravity? It's going to be challenging. And we're going to see two major pumps that will be allowing the blood to move back towards the right atrium. But because I have a very low pressure, I'm afraid that this blood flow will not be kept in this direction. So to ensure the unidirectional flow of the blood and to prevent any backflow of the blood, I need to secure this blood movement in the veins by having valves. So you see on here, veins will have valves, but they are not present in the arteries. Again, why not in the arteries? Because simply the arteries have a high blood pressure compared to the veins. Another major difference that you can notice on here is the lumen, the cavity inside the vessel. So if you notice on here, arteries have a very small lumen compared to the veins, they have a much larger lumen. So veins have more space for the blood to be kept compared to the arteries, which will have a very smaller space. Other differences that you can notice, you see on here, tunica media in the arteries is going to be much thicker compared to the veins. Arteries will have much larger muscle layer compared to the veins. So I have much larger tunica media in the arteries compared to the veins. Another major difference that you can notice also is going to be the presence of a lot of elastic tissue in the arteries. A lot of elastic tissue here are present. Those elastic tissue layers are present here to allow the pulsatile blood flow, as we're going to see in a second. If we're looking here at the structure of the capillary, you will notice that the capillaries are only formed of one row of flat cells, simple squamous epithelium, endothelium, and those are lying on a very delicate basement membrane. Unlike the arteries and veins, they don't have those three layers, tunica intima, tunica media, and tunica externa. They are formed just by one row of flat cells lying on a basement membrane. Moving on to the arterial system, first we're starting with the largest type of arteries. Those are my elastic arteries. And elastic arteries, another name that we use for is going to be the conducting vessels. Elastic arteries, they have a very thick wall containing a lot of elastin. almost in all the three tunics, tunica, intima, media, and external. And those are going to be the aorta and its major branches, like the brachiocephalic artery, common carotid arteries, the subclavian arteries. Those major arteries and the aorta, they are classified as elastic arteries because they have a thick layer of elastin in their structure. This will tell us why do I have two blood pressures. So when I have a blood pressure reading, how many blood pressures would I see? If I go today to the pharmacy to check my blood pressure, how many blood pressures would you get? How many numbers would you get? Get two, right? Those are systolic and diastolic. So it's going to be around 120/80 on average. What is systolic blood pressure? What is diastolic blood pressure? First, we mean by blood pressure is the pressure of the blood. But we mean by this, it is the pressure by the blood in the arteries. This is what we're concerned with. So actually, it's arterial blood pressure, not just blood pressure. And what do I mean by blood pressure? What creates the pressure? What creates the pressure is the blood flow. If I have a flow and this flow is moving against some kind of resistance, so I have something that moves and I am resisting the movement, what is created in between, it's what we're going to call the pressure. What applies the resistance here against the blood flow is the wall of the arteries. So what do I mean by the blood pressure? I mean by this that when I measure the pressure applied by the blood flow on the wall of the artery, it's equal to 120/80. So again, what do I mean by blood pressure? Blood pressure simply means that the blood that flows in my arteries pushes the wall of the arteries by a force of 120 mmHg or 80 mmHg. This is what we mean by blood pressure. What do I mean by systolic? So you've got 120 is systolic blood pressure and 80 mmHg, it's the diastolic blood pressure. What do I mean by systolic and diastolic? If blood pressure means the pressure applied by the blood flow on the wall of the artery, what do I mean by systolic? What do I mean by diastolic? If you remember, systole is ventricular contraction. Diastole is ventricular relaxation. So what do I mean by a blood pressure which is systolic blood pressure? This means that the blood flowing in the artery applies a pressure on the wall of the artery during ventricular contraction, and this pressure is equal to 120 mmHg. What do I mean by diastolic blood pressure? Again, what is blood pressure? Blood pressure means the pressure applied by the blood flow on the wall of the artery. So diastolic blood pressure means that the blood that flows inside the arteries is pushing the wall of the artery out when during ventricular relaxation by a pressure of 80 millimeter mercury. This is what we mean by diastolic blood pressure. This raises a question here. This means that during ventricular relaxation, the blood in the arteries is going to be moving, right? So I can understand that when I contract, the blood is going to be ejected out of the ventricles, so it's going to be moving, applying a pressure. But is the blood going to be moving during ventricular relaxation? Yes. If it didn't move, it wouldn't have applied this pressure. So who is pushing the blood to move when the heart is relaxing, when the ventricle is relaxing? Who is pushing this blood forward for this blood flow to apply a pressure? What do you think? What keeps the blood moving when the ventricles are relaxing? What do you think? If I'm relaxing, am I pushing the blood? Am I pushing the blood if I'm relaxing? If I'm relaxing the ventricle, am I pushing the blood out? Am I pushing any blood out? I'm not. I'm not pushing any blood out here. But what actually allows the blood to be kept moving even when my ventricles are relaxing is actually the elastic tissue in the wall of the elastic arteries. So what happens during ventricular contraction? The elastic arteries will expand like this. Expansion of the artery because it has a lot of elastic tissue. So the blood that flows in the artery applies a pressure of 120 millimeter mercury rather than 300 millimeter mercury because the wall of the vessel did expand. It did not resist the blood flow. If it was tense, if a person has atherosclerosis, in his large arteries, what do I expect to see? If those arteries are so tense, they are not expanding, what's going to happen to the blood pressure? Up or down? Increase, decrease, or no change? Can you remind me what was the relation between the volume and the pressure? If I increase the volume, what happens to the pressure? If I increase the volume, what happens to the pressure? The volume of a container. If you increase the volume, what happens to the pressure inside? Increase volume, like when you relax the heart, when you relax the ventricle, it did expand the volume. What happens to the pressure inside? Will it be increased or decreased? It will decrease, right? Pressure goes down. Remember, when volume goes up, pressure goes down. So looking at here, This artery, when expanded, when you expand the artery, this means when you increase the volume of the artery, the pressure inside is going to be 120 millimeter mercury. I'm telling you that a person has atherosclerosis in those arteries, so he's not able to expand. So what happens to the volume? If I'm not able to expand, this means I have a smaller or a larger volume. What do you think? Is my volume going up or down? Am I increasing volume or reducing the volume? If I fail to expand, do I have a smaller volume or a larger volume? Smaller volume, exactly. So what happens to the volume on here in the patient with atherosclerosis? He has a reduction in the volume of his arteries. Those large arteries, they are not expanding. So what's going to happen to the blood pressure inside? If I'm not expanding, what's going to happen? The blood pressure, it goes up. So this patient with atherosclerosis, because he has accumulated lots of fat in the wall of his arteries, what's going to happen? So his arteries, or those large arteries, will fail to expand. So this will reduce his ability to reduce this systolic volume. So you will see this patient with a high systolic blood pressure. Why? Because simply I'm not able to expand the artery as I should. And what happens normally during ventricular relaxation? When the ventricles are relaxing now, I'm not pumping any blood out, but who's gonna pump the blood for me to be kept moving forward towards my organs, even if when my ventricles are relaxing, is the recoil force of those elastic arteries. So the arteries are expanding during ventricular contraction, and they will recoil. And when they recoil, what's going to happen to the volume? What happens to the volume when you recoil back to your normal size? What happens to my volume, the volume inside? This is expanded. See on here, this is expanded. And you recoil. What happens to the volume? When a balloon recoils, when it recoils, what happens to the volume? Decreases. And when you decrease volume, what happens to the pressure inside? When you decrease the volume, what happens to the pressure inside? Increases. So rather than having, I'm not pumping any blood, so the pressure should be zero. But because I recoiled, those arteries did recoil, this recoil force will reduce the volume, and when it reduces the volume, it increases the pressure. So the pressure, rather than being a zero pressure, now the pressure goes up to 80 millimeter mercury. Moved the pressure rather than being a zero pressure during ventricular relaxation, because the ventricles are not pumping any blood. So the pressure is zero pressure. Nothing is good. Nothing is pumped. So this recoil force makes it jump to 80 millimeter mercury. So what do we call this here? The pulsatile blood flow. You see on here, during ventricular contraction, those elastic arteries did what to the pressure? I did reduce the pressure. I did store some pressure for you to use later on during ventricular relaxation. Here I am acting as a pressure reservoir. So some pressure has been stored during ventricular contraction by expanding the wall of the artery. And this stored pressure will be used later on during ventricular relaxation to keep the blood moving when the ventricles are relaxing during systole. All right, questions? All right, moving on to our next type of arteries. This is going to be my muscular or distributing arteries. Those are located distal to the elastic arteries. They are branches from the elastic arteries. They have a thick tunica media that consists of smooth muscles. And they will be delivering the blood to the different body organs. And from their name, the most important characteristic is that they have a thick tunica media. That's why we call them muscular arteries. So what is the importance here of having a thick tunica media while I'm distributing the blood to the different organs? I'm a distributing vessel. So, for example, I'm going to the stomach here. I'm sharing in the blood supply of the stomach. I am a muscular artery, and there is another muscular artery on here that is supplying the blood to a skeletal muscle. Right. As those are both two different muscular arteries. If I decided to run, which one would you like me to give more blood to? My skeletal muscle or my stomach? If I'm exercising, which one should I be giving more blood to? Skeletal muscles, right? So where do you get this extra blood from? First, you're going to increase the cardiac output. Remember, you're going to be increasing the stroke volume. You're going to increase the heart rate. It can go up to 4 or 5 times. Not only you're increasing the cardiac output, but also you are redistributing this blood. And we're going to see different ways by which we're going to be redistributing the blood. And one of them is going to be by constricting those muscular arteries, creating a high resistance against the blood flow. And this artery here is going to be dilating, allowing a reduction of the resistance at this organ. So what's going to happen if you are the blood? Which one would you go to? Would you go to your stomach or would you go to your skeletal muscles? Would you go through a high resistance or a low resistance vessel? Which one would you prefer to go to? You're going to go to the side with lower resistance. So blood is going to be shifted from the stomach to be directed towards my skeletal muscle. So again, why do I need this thick tunica media formed of many layers of smooth muscles in order to be able to contract and dilate according to my needs, to regulate the amount of blood that gets delivered to the different organs. Moving on to the third type of arteries, those are the arterioles. This is the smallest type of arteries. They will be conducting the blood towards my capillary beds. And because I have many arterioles, this creates a high resistance. This will make them of higher resistance. If you see on here, The other name actually that we give to the arterioles is the resistance vessels. Arterioles are my resistance vessels. Why? Because you've got many of them. They have a much smaller diameter compared to the muscular arteries. And again, we're going to be using those arterioles to dilate and to constrict to regulate the blood flow to the different capillary beds. So I'm regulating not only at the organ level, but also at the tissue level. A third type of, or the second type of blood vessels, it's going to be the capillaries. And again, the capillaries, those are my exchange vessels. Those are the ones allowing the exchange to take place between the blood and the tissue cells. They are formed of a very thin tunica intima, just one row of flat cells. You don't want to have a high resistance against the fluid movement between the blood and the tissue. This size, they have a diameter, a very small diameter that only allows one red blood cell to pass at a time. So if we're looking here at a capillary, it's a very delicate vessel formed of one row of endothelial cells, and it has a very small diameter as well. So it has a very small diameter on here that will only allow a single red blood cell to pass at a time. So only one red blood cell is capable to travel here through this small diameter. It's present in almost all tissues except for the cartilage, epithelium, and in the eye. It's not going to be present in the cornea or lens of the eye. So again, it's going to be present in all different tissues except for epithelium, cartilage, and in the eye, it's not going to be present in the cornea and lens. Many functions, and the main function here will be to allow exchange to take place, exchange of gases, exchange of nutrients, waste, delivery of hormones. All this exchange is going to be taking place between the blood and tissue cells in the capillary beds. We classify the capillaries into three main types according to the structure. First type of capillaries here, those are going to be formed of one row of flat cells like this. The only way for fluids to travel in and out of the capillaries is to pass between those endothelial cells. Those are what we call the intercellular clefts. Those are called my continuous capillaries. Those will allow the lowest permeability. Another type of capillaries, again, according to the structure, those are the fenestrated capillaries. They are very similar to the continuous capillaries, except for one thing that those epithelial cells forming the capillary will have pores or fenestrations. So those endothelial cells will have fenestrations or pores, which will allow a moderate permeability. And again, why do we call them fenestrated capillaries? Because of the presence of those fenestrations. In the endothelial cells. A third type of capillaries, according to the structure, is going to be my sinusoidal capillaries. And the sinusoidal capillaries, again, are formed of one row of flat cells. But if you notice, those capillaries, they will have larger intercellular clefts, and their endothelium is going to have much larger pores or fenestrations. So the fenestrations of the sinusoidal capillaries will be much larger than the fenestrated capillaries. And this type of capillaries will allow the highest level of permeability. Again, those are my sinusoidal capillaries. So again, three types of capillaries that we're looking at. The first one is going to be my continuous capillaries, allowing the minimal resistance, allowing the minimal permeability, I'm sorry. The only way for the fluid carrying solids to travel is going to be through the intercellular clefts, which are so tiny in this type of capillaries. Second type of capillaries, again, according to the structure, is going to be my fenestrated capillaries. Will allow a greater permeability compared to the continuous capillaries because of the presence of those pores, those fenestrations in the endothelium. And again, the third type is going to be the sinusoidal capillaries, which allows the maximal level of permeability to take place between the blood and the tissues. And you can notice on here that this type of capillaries will have a much larger fenestrations and much larger intercellular clefts. All right. So where do you think I will need those three different types of capillaries? In which organs? No, those are three different types. And each of those types is going to be present mainly in specific organs. So where do you think I will need continuous capillaries with the least permeability? Where do you need just to allow some solids and fluids to pass in and out from the blood? You're not conducting larger metabolites, muscles, skin, and brain. I don't need much of the large metabolites or cells to pass in and out between the blood and the tissues. Here's skin, muscle, and brain. compared to the fenestrated capillaries, where I have larger pores, as you see here on the diagram, have larger spaces, but those are pores within the endothelium. I need more permeability than the brain, than skin and muscles. Where do you need to conduct larger metabolites? In the kidney, for example. Why? To allow the filtration of the blood. Kidneys, they are filtering the blood, so I will need a lot more permeability for much more fluids and solids to travel from the blood to the kidney tubules in order for the blood to be filtered. Where else? In my small intestine, for example. Why in the small intestine would I need higher permeability? Why in the small intestines would I need fenestrated capillaries? Because I'm absorbing here nutrients which are large chemical structures that will be passing from the intestinal cells to the capillaries, to the blood. So I need it in the small intestine, I need it in the kidney, and in my endocrine glands. If you remember, why do you think you're going to need this type of capillaries in the endocrine glands, do you think? Why do I need it in the endocrine glands? What is the function of the endocrine glands, if you remember? To produce chemical messengers which are traveling in the blood. So remember, I need to release hormones, and those hormones will need to find their way out from the gland into the blood for it to be delivered to the target organ. So in order for those hormones to find their way to the target organ, I need to pass this large amount into the blood. So what kind, again, of capillaries do I have in the endocrine glands? Is going to be the fenestrated capillaries that will ensure the passage of large chemical compounds. Moving on here to the sinusoidal capillaries with the highest permeability. You see, as on the diagram, they have much larger pores in their endothelium, and they have large intercellular clefts between the endothelial cells. Those are not only allowing large chemical compounds to travel, but they are also allowing cells to pass in and out from my capillaries. So in which organs would you be willing to allow cells to pass in and out of your blood stream? Not only allowing chemicals, you're allowing cells. Why the bone marrow? Bone marrow, definitely. Because this is where the blood cells are going to be formed. This is where the blood cells are going to be formed. So I have a red blood cell, for example, gets formed where? In the bone marrow. So it needs to leave the tissue and enters the circulation. So I need a type of capillaries that allows those cells to travel, which is my sinusoidal capillaries. Where else? Spleen. Why in the spleen? In the spleen, you're going to be storing large number of white blood cells. And those white blood cells are going to be waiting to become activated and get released out in order to fight infection. So here, I need a type of capillaries that will allow the cells to be transported in and out of my circulation. A third place It's gonna be the liver, but it's not only in the liver about moving cells, but also about moving any chemical compounds that you get exposed to. It needs to pass through the liver. Remember, all the blood that gets drained from the gastrointestinal tract, starting from the stomach down, all this blood gonna be delivered to the liver in order for it to metabolize. For the kidneys, remember, if you are tempted, that the kidneys have a higher higher permeability, like they have sinusoidal capillaries. They do not have sinusoidal capillaries. Remember, they have fenestrated capillaries. All right. Remember, I don't allow blood cells to pass out in the urine. Remember, you don't allow blood in the urine. But the liver, have you ever got a liver before from a grocery store, or have you ever seen a liver in the grocery store? Anybody? Yeah, it has a lot of blood. All right, so after class, you can go to Walmart or Publix and check a liver. You'll see it has lots of blood in it, lots of blood, because the liver has what type of capillaries again? Those large capillaries with the highest permeability, allowing cells to move in and out. All right, so it has a lot of blood. Comparing it to something like the meat, the muscles, it won't have much blood like the liver. All right. So again, according to the structure, how many types of capillaries do we have in the body? We have 3 different types. What are those 3 different types again? First, the one with the least permeability is going to be my continuous capillaries, and it allows only fluid and small solids to pass between the endothelial cells through those small intercellular clefts. And again, where do I see this type of capillaries? This is going to be in the skin, muscles, and the brain. Second type of capillaries with more permeability than the continuous type because of the presence of fenestrations or pores is going to be allowing greater absorption and filtration, and this is going to be required in organs like the kidneys, the endocrine glands, and the small intestines. A third type of capillaries, according to the structure, is going to be the sinusoidal capillaries, and those are the most permeable from the 3. They have fewer tight junctions between the cells. They have larger intercellular clefts, and they have large lumens as well. They are fenestrated. And again, if you remember, those won't only allow large molecules to travel in and out of the bloodstream, but they will also allow blood cells to pass through. Where do I where can I find those sinusoidal capillaries? Spleen, bone marrow, and in the liver. All right. Questions? Anything which is not clear so far? All right, so for question number 4 today, the in-class activity, please answer this question here for me. What vessels carry blood away from the heart? Carrying blood away from the heart. Capillaries, veins, arteries. Which one would you pick? Arteries, exactly. Moving on to another classification here for the capillaries. And this consists of 2 types according to the function of the capillary. So the capillaries are located embedded in between the tissue cells. Remember, the blood gets delivered to the capillary bed through an arteriole, and the blood gets drained out from the capillary bed through a venule. We call this is a precapillary arteriole, and this third one, and the third one is my venule. All right, so in between we've got the capillary bed. So a type of vein of capillaries that we're gonna have is just serving as a shunt for the blood to move directly between the arteriole to the venule without performing any exchange between the blood and the surrounding cells. We call this is my vascular shunt. No actual exchange is going to be taking place between the bloodstream and the cells outside. Another name for it, or the meta-arteriole, is going to be the meta-arteriole. Those are again shunts that will be connecting the arteriole to the venule without an actual exchange taking place. Another type of capillaries, those are branches from the shunt and to the shunt like this. And those are going to be guarded by muscle sphincters. So you have muscles surrounding the base of each of them, as you see on here. Those are the actual capillaries that will allow the exchange to take place. This is where the exchange between the cells and the blood gonna be taking place. That's why we're gonna call those capillaries are my true capillaries. In each capillary bed, we're gonna have 10 to 100 true capillaries embedded in the wall. So again, we're looking here at 2 different types of capillaries according to the function. According to the function, we've got just connections that are not allowing any gas exchange to take place. What do we call those ones, or any exchange of any type to take place between the bloodstream and the cells? Those are called my meta-arterioles or vascular shunts. Branching of the meta-arterioles, we've got the true capillaries. Those are the actual vessels that will perform the exchange, and those are again guarded by the sphincters on here, as you see on the diagram. And those sphincters will allow you to regulate the amount of blood that gets delivered to a certain organ. So if, for example, I am working out, we're looking here at a capillary bed in the stomach. Would you like a lot of blood to reach the cells of the stomach here? If I'm working out, this blood got already delivered to the arteriole. Would you like it to exit the meta-arteriole to reach the muscle cells of the stomach to perform exchange or not? What do you think? If you are exercising, would you like more blood to be delivered to the wall of the stomach or less blood? Less. You're not using the organ, so it doesn't help you to actually deliver the blood from the meta-arteriole to the true capillaries. So what you're gonna do, you're gonna be constricting those sphincters. How about in your skeletal muscles? If you are exercising, would you like more blood to perform exchange or less blood to perform exchange with the muscle cells here on the side? Those are muscles. And I'm exercising. I want to be delivering more or less oxygen to my tissues, muscles, in the skeletal muscles. You want to deliver more nutrients, more oxygen. So what you're going to do, you're going to be relaxing those precapillary sphincters, allowing the blood to pass into the true capillaries from the meta-arterioles. So again, two types of capillaries according to the function. According to the function, we've got meta-arterioles, which are simply shunts that will allow the blood to travel from the arteriole to the venule without performing any actual exchange with the tissue. Another type of capillaries, those are the true capillaries. And they are branches from the meta-arteriole, and their base is guarded by the precapillary sphincter. And those are the actual capillaries that will be performing the exchange with the cells. Questions? We're looking here at the cardiac output and the amount of blood that gets delivered to the different organs during rest and during exercise. So if it did pass, so here I got a question. If the blood is passing from the arteriole to the venule, how come it became deoxygenated if it doesn't perform exchange? Because simply it gets mixed with the deoxygenated blood. So it's going to be mixed with the deoxygenated blood. So the oxygen level is going to be dropping anyways. But the key concept on here is not only about delivering the blood, not delivering blood to an organ that you're not using, is also to create higher resistance. So imagine on here, if I have 5 routes or 10 routes that I'm traveling in, it's going to be much easier for me than if I have only one route that I need to travel through. So constricting the precapillary sphincters is going to be creating higher resistance for the blood to get into the capillary bed. So the blood is going to be shifted away from this capillary bed. So try to imagine that you have 5 pathways. So how many people can you get in? 1, 2, 3, 4, and 5. So 5 people can get in. So if you closed 5 routes, 4 of those 5 routes, so only 1 person can get in, and the other 4 will be trying to find another way to pass. So we're looking here. So only one of those pathways is available, so only 1 person can travel in, which is through the meta-arteriole, and the rest will have to find another pathway with less resistance. Yeah, so less blood traveling. Yeah. It's not like I'm reserving the oxygen to be used in a different organ. All right, so we're looking here at the distribution of the blood to the different organs. We're looking first during rest. What is the cardiac output? If you remember, what's cardiac output? This is the amount of blood that gets pumped from the ventricle per minute. And if you remember, how did we calculate this? We checked the blood that gets pumped from each ventricle in a single contraction, and we call this a stroke volume, and we multiplied the stroke volume by the number of beats per minute, or the heart rate. This gives you the cardiac output. If you remember, the cardiac output during rest is about 5 liters, or 5 to 6 liters. All right. During exercise, if you remember, we stated that cardiac output can go up for 5 times. So let's say here it's about 18 liters. So while the cardiac output during rest is 6 liters, what is the distribution of this blood to the different organs? Brain is getting around 750 milliliters. Heart is gonna get almost a quarter of a liter of blood. Skeletal muscles will get around a liter of blood. Skin is getting half liter. Kidney, a liter of blood. All the rest of the abdomen is going to get a liter and a half. So when I exercise, I want to get more blood delivered to the skeletal muscles, right? So let's say here 18, you divide it by 6. So the cardiac output has been 4 times the resting cardiac output. So what is the amount that you're expecting to be reaching your skeletal muscles when you exercise? If I'm telling you that during rest, you're pumping 6 liters of blood per minute. And when you exercise, you're going to be pumping 18 liters. All right, so 6, 12, 3. So those are 3 times. $18 liters of blood per minute. This is during exercise. And I'm telling you that during rest, your skeletal muscles are getting around 1 liter of blood per minute. What do you think is the amount of blood that will be reaching skeletal muscles during exercise? So you see on here, 6 liters per minute during rest is the total cardiac output. It's going to be 3 times. During exercise. So what do you expect the number, the amount of blood that gets delivered during exercise to the skeletal muscles, according to what we see on here? According to what we see on here, how many liters of blood are going to be delivered to my skeletal muscles if the cardiac output did increase 3-fold and I was getting 1 liter? So I'm expecting it to be, I see one answer. How about the others? So again, my question, during rest, I was pumping 6 liters per minute from my ventricle to be delivered to all organs. And now when I exercise, I increase the heart rate and I'm now pumping 18 liters, which is 3 times the amount I was pumping during rest. If I told you that the skeletal muscles during rest were receiving just 1 liter of blood, so what's going to be the amount that I'm expecting the skeletal muscles to be receiving when I exercise? 3 times what you were receiving during rest, right? So I'm expecting to see here during exercise that I'm getting 3 liters of blood per minute. But I want you to look here at this diagram and tell me what is the actual amount of blood that's going to be delivered to your skeletal muscles. $12.5 liters of blood. How come? How come? I was expecting the skeletal muscles to receive 3 times the amount it was receiving, they were receiving during rest, because the cardiac output has increased 3 times the amount as during rest. How come? I'm not only increasing the cardiac output, I did also redistribute this blood circulating in my system. So I did what? I did, you remember? I did contract the artery, the muscular arteries going to other organs. I'm contracting the arterioles of less important organs. I've contracted the precapillary sphincters in the other organs. So what's going to happen? Less blood gets delivered to the other organs and more blood gets delivered to my skeletal muscles. So skeletal muscles are not going to get only 3 times what they were receiving during rest. They will get 10 times, 12 times the amount that they were receiving during rest. All right, so it's not every organ gonna get 3 times the amount as during rest. So for example, the brain, if you see on here, still receives the same amount as during rest. Same amount as during rest. Heart did get 3 times the amount of blood. And this is so simple to explain because you see on here, it did perform 3 times the amount of work. So it's gonna need 3 times the amount of blood to get its needs from the oxygen and nutrients. But looking at something like the abdomen and the kidney, you see, kidney and abdominal organs are now receiving even less blood compared to during rest because your stomach works under the effect of parasympathetic, which is activated during rest. And the same for the other abdominal organs. Compared to if we're looking here at the skeletal muscles are we're receiving a liter of blood, liter 200 milliliters. Now they are receiving 1200 milliliters. All right, 10 times the amount of blood than during rest. Again, what is the most important contributing factors to allow this redistribution to take place? Constriction and dilation of the pre-capillary sphincters to direct the blood away from the organs of less importance to the organs with greater importance.